So let me show you a bunch more of these. What's that? Young people can have high voltage very commonly. The Q waves are what really is abnormal. Okay, question?
This guy seems to have an ectopic atrial rhythm. Is that related to his HOCM?
Yeah, he does. It's just an unrelated thing. All right. So another example: high voltage, deep narrow Qs 1, AVL, V5, V6. Another example: high voltage. You can get abnormal T waves sometimes just with the high voltage, but take a look at these Qs. Very deep, very narrow. Lateral leads. Another example: high voltage, deep narrow Qs 1, AVL, bit, and V5, V6. Very narrow, very deep. Another example: high voltage, relatively high voltage, deep narrow Qs 1, AVL, V5, V6. Another example: take a look at this. High voltage, not much in 1 or AVL, but take a look at these Qs in V5, V6. Very deep. They're like daggers. Okay? There's just nothing else that gives you Qs that look like this in cardiology. All right? So when you see high voltage with deep narrow Qs in a young person especially, why do you do EKGs on young people? You don't worry about ischemia all that much. When you get EKGs, you always look for ischemia. You always look for arrhythmias. Hopefully you're looking for WPW and prolonged QT. Add this to the list. Add hypertrophic cardiomyopathy to the list. And when you see it, just send them for a Doppler echo. You'll save a life. All right? Just a simple EKG finding. You make the diagnosis at Doppler echo. You'll save somebody's life. Because otherwise, the next time they go out and exert themselves in some way, they might just happen to drop dead. Yeah.
That's a sensitive question, just because I've only learned about relevant science today. But a lot of those look like they had that sort of shape.
Yeah. You can get abnormal T waves in association with very high voltage. And I didn't say this before, but Wellens really should not be diagnosed in the presence of high voltage. Because high voltage in and of itself can really mess up your T waves just because of the abnormal repolarization.
Also, I'll just have a different way of thinking about the young symptoms. So when the other group of people that learn this is pediatricians, because we don't do echo, so it's just a young person who's fallen over. Before you say they're a faint, you've got to look for a few other things.
Yeah. At the end, I'm going to summarize the differential for syncope. What kind of things do you look for on EKG? Wait, say that again? I haven't heard that. You mean these? I mean, yeah, I haven't heard that. It may be possible, but I haven't heard that as being a very specific finding. Right. Now, the other one that everybody's become very knowledgeable about, I think, is this. What is this one? Brugada, right. So, and this is another finding that occurs oftentimes in young patients. And what you see with this is an electrical phenomenon, so it's not anatomic. If you do autopsies on these patients, it's completely normal. There's no coronary lesions, ventricular hypertrophy, septal hypertrophy. There's no LVH, there's nothing. It's purely electrical. And the prevailing theory now is that it's a sodium channelopathy. There's some type of sodium channel abnormality. But there's a lot of research going on trying to figure out what causes this. The average age of diagnosis is about 30 years old, 30 to 40. So although this was first identified in adolescence as a common cause of sudden death in Southeast Asia, it's now been identified average age 30 in both men and women, every country, every ethnic group. And they estimate that this may be as prominent as 0.1% of many populations, which means if you're in an emergency department, you can count on seeing this on a relatively regular basis. Brugada syndrome is now believed to be so common that 1 out of every 20 to 25 cardiac arrests is attributable to Brugada. Putting peds aside, because we don't know the numbers there, putting trauma arrest aside, if you take a look at all medical arrests, 1 out of every 25 medical cardiac arrests is attributable to Brugada. Now, if you see the patient when they're in cardiac arrest, it's often too late. But if they present earlier after a syncopal episode, that's your time where you can save a life. You can make the diagnosis. So why does syncope occur? Because they have an arrhythmia that terminates. These patients have a propensity to develop polymorphic VTach. And if they're lucky enough for it to self-terminate, they present after syncope. If it doesn't terminate, then they end up with sudden death. So you see, syncope and sudden death are in many cases the same disease along a continuum. All right? And this patient had a bad outcome. This is a 30-year-old who came in after a syncopal episode. She was died, a bunch of labs were sent, monitored. Nobody knew what to make of this. She ended up being discharged home, and she had a cardiac arrest several days later, 1 week later, and died. And that's when I found out about her and pulled the EKG. So what you're going to look for, now the leads that you focus on, leads V1 and V2. All right? And you're going to look for a right bundle type of pattern with ST elevation. Now recall what I said earlier about right bundle. Right bundles normally give you a little ST depression in V1 and V2. So when you see ST elevation with a right bundle in V1 and V2, that should really stand out as abnormal, especially if they came in because of syncope. All right? So there's two types of elevation. There's concave upwards, and there's convex upwards, or coved. The cove type is much more sensitive and more specific and more worrisome. If you see this on a patient that you got the 12 lead because of syncope or palpitations or something that you think may have been an arrhythmia, get on the phone with an electrophysiologist. The definitive test is in electrophysiology testing, and then what they'll do is they'll infuse into the patient a sodium channel blocker to really block the sodium channels and bring out the abnormality even more, or, frankly, induce polymorphic VTach. If they're successful in doing that, they shock them back and then place an IC. It's a lot of fun, I guess, but they place an ICD, and with placement of an internal defibrillator, the mortality drops to 0. 100% survival. Without the ICD, mortality is 10% per year from the time symptoms begin. And nobody knows why symptoms suddenly begin at 20 or 30 or 15 or 40 or whatever. All right? So let me show you a bunch of examples just to really hammer home this visual finding. Okay? So, cove type of elevation, right bundleish pattern, V1, V2 with coved elevation. Sometimes it extends to V3. Usually V1 and V2 are your main leads. Here's another nice example from our hospital. Again, ST elevation, V1, V2 with the right bundle type of pattern. This is a first-year medical student from Ohio that was sent to me. He was having syncopal episodes, and it wasn't in the cadaver lab, so they really got worried. Okay? So they sent him to student health. He got this 12 lead. He's got Brugada pattern, ST elevation with coved elevation, and extends down to V3. So he got an ICD and did well. Had this not been diagnosed, this first-year medical student would have had a 30 to 40% chance of dying before graduation. This was a 50-some-year-old woman that I took care of. She presented in cardiac arrest. We got her back. She lives currently with hypoxic encephalopathy in one of our local nursing homes. This 12-lead EKG was taken in her doctor's office a week earlier after she presented with the syncopal episode. You can see that there's that Brugada pattern. Had this been recognized, she would have had probably a very different outcome. Now, I don't think it's standard of care for most primary care physicians to know about this. I don't think my wife knows about this. And I talk about EKGs all the time. Actually, I'm not allowed to talk about EKGs at home anymore. But most primaries don't know about this, which is why I fly all the way to Cape Town just to talk to you. People are still learning about this. Right bundle with ST elevation, V1, V2. Another example, this is mild elevation, right bundle pattern. For comparison, this is a normal right bundle. Remember, a normal, uncomplicated right bundle, you have a little ST depression. So when you see ST elevation, it should really jump out as abnormal. All right, here's the saddle type of morphology, little elevation there. Okay, this was sent to me, 39-year-old having near syncopal episodes. Nice Brugada pattern V1. This was one that a friend gave also, ST elevation V1, V2. Is this pattern becoming kind of stand out to you? Okay, good. All right? And this was a patient that was diagnosed in an emergency department after a cardiac arrest and got sent to university to the electrophysiologist. The electrophysiologist looked at this and said, this is definitely Brugada. The electrophysiologists love this stuff. They live for this. They dream about this. They go to international conferences to just talk about Brugada. There's been 2 international consensus conferences on Brugada syndrome. Can you believe that? Going to an international conference and all you talk about is one disease? Thank God I'm in emergency medicine. Okay, but the non-electrophysiologist hadn't heard of this before, and he called it a septal STEMI. Okay, so not all cardiologists know about this yet either. Okay, again, classic symptom, a classic finding. This is the oldest one that I've heard of. This was sent to me by a friend in near Atlanta, Georgia, 60-year-old man. And Dr. Watley was worried about the Brugada pattern, called up his electrophysiologist who said, nope, can't be Brugada, this patient's too old. It was first described in adolescence, just rule the patient out and discharge. So he pushed and pushed and pushed and pushed. And finally, he had a very good relationship with this electrophysiologist. They're friends. Finally, this electrophysiologist said, okay, fine, I'll take him to the EP lab where he gave him some sodium channel blocker and did this. So the patient got an ICD, and the electrophysiologist called back Greg and said, thank you, you saved this guy's life, because I would have sent him out. All right. Another classic pattern. Now, this is after syncope. Supposing you see this pattern after a patient's showing up with chest pain, this is a septal STEMI. All right? So the history is important. If they're showing up with chest pain and you see this, I call that a septal STEMI. But if they presented after syncope or near syncope, then you worry about Brugada. Okay? So take the history into account as well. All right. Brooke Shields. You guys know Brooke Shields? All right. If you ever need some advice about how to convince people to stop smoking, Brooke Shields had the best way of doing it. Just tell them, smoking kills. And if you're killed, you've lost a very important part of your life. And, of course, there's a few pages of Britney Spears as well. Britney never took geography in school. You all will appreciate this. I've never really wanted to go to Japan simply because I don't really like eating fish, and I know that's really big out there in Africa. Somebody said, so Brittany, what do you like so much about being a celebrity? She said, oh, I get to travel overseas, places like Canada. Now, just so everybody knows geography, okay, you can actually travel from California to Canada overseas, okay? So, all right, okay. Number 15, last couple, I think. 40-year-old woman presents after syncope or seizure. I'm not really sure what happened. What do you think the diagnosis here is? We've talked about this a couple times. Good. Great. Prolonged QT. Okay? Prolonged, and she recently started some new antipsychotics. She's got prolonged QT. So, prolonged QT causes polymorphic VTAC, and if it terminates spontaneously, it causes syncope. Now, as you know, sometimes people that have syncopal episodes, when they fall, they shake a little bit. And what does everybody standing around think is going on? A seizure, right? So the neurologists oftentimes say, not everything that falls and shakes is a seizure, okay? So how do you tell the difference? Well, syncope can give you some myoclonic jerks, usually 5 seconds, maybe 10, not 30 seconds, not a minute. That's a seizure. If it's just 5 or 10 seconds, that's not a seizure, okay? Also, no postictal period after syncope. So be careful when people come in saying, I had a seizure, or my sister had a seizure, my brother, some witness says seizure, all right? And one of the common causes of seizures is actually an arrhythmia, and it's not a true seizure, all right? In fact, there's many case reports in the literature of people that have been treated for years for a seizure disorder, and then somebody finally monitors them, and it turns out that they're actually having episodes of polymorphic VTAC. It's a nice case here. Patient got brought in by the paramedics saying she had a seizure. So we got a 12-lead EKG. And by the way, if you look in any textbook at the workup for a new first-time seizure, it always includes an EKG. Why? Because of this. We got the 12-lead EKG. She's got a prolonged QT. So we put her on the monitor, and we watched her, and she did have a couple more seizures. Each one was preceded by this. she was having polymorphic V-tach that was causing transient hypoperfusion to the brain. She'd shake a little bit, and that was it. All right. So one case report in International Journal of Cardiology about 2 years ago, there was a teenager that had been treated for 5 years on various anti-epileptics. And finally somebody monitored him, and it turned out that he just had prolonged QT, believe it or not. This type of thing gets published every now and then, and I don't know how many cases are not being published. So always check that EKG, okay? So dysrhythmias can produce seizures. So we've talked about prolonged QT. Here's your differential. Whenever you get an EKG in a syncope person, here's what you should always look for. Everybody already looks for acute coronary syndrome. Everybody already looks for tachy and Brady dysrhythmias. All right? Please add this to your list. Prolonged QT. There's a new entity called short QT syndrome that I'm not going to talk about because it's enormously rare. All right? And also WPW. Add WPW to the list. Add hypertrophic cardiomyopathy to your list. High voltage and deep narrow Qs in the lateral leads. And by the way, that's not 100% sensitive, but it's very specific. All right? And add Brugada to your list. Whenever you've got a syncope or a near syncope or palpitations kind of person, and you check a 12 lead, go through your checklist. These are all the things you've got to make a habit of looking for. And again, these are people that show up after syncope, and they're wide awake, alert, they're happy, they're asymptomatic, and if you miss one of these, they're going to go home and die. So here's an opportunity to save a life just by knowing something about the EKG. All right? And this is the last one. I think it's the last one. It's another T-wave abnormality, which you might want to just keep in mind. If you don't have quick access to a CAT scanner, you're tapping your head. Right. When you see deep, wide T-wave inversions in somebody with an altered level of consciousness, almost always that's elevated intracranial pressure from a bleed. Okay? So let me show you a bunch of other examples. All of the following are patients with altered level of consciousness who had head bleeds. Take a look at these T-waves. Huge T-wave inversions. Right? Sometimes these are referred to as roller coaster T-waves or cerebral T-waves. They can be 15, 20 millimeters in depth. All right? This was a patient, actually, I got a patient sent in from the nursing home who I got a call. They said this patient had a syncopal episode. So I thought, all right, well, she's 75 years old. She's from the nursing home. All I got to do is just admit her. She shows up. She's got T-wave inversions, which are, here's the old EKG. All these T-wave inversions are new. So I thought, well, this is a piece of cake. She's got cardiac ischemia. Technically, it wasn't syncope because she's still out of it. So I put an order in for heparin and aspirin, and the family shows up. And so we're talking a little bit. And they say, oh, well, she's got metastatic cancer with mets to the brain. And I said, of course. I'll be right back. So I ran over to her. So I told the nurse, don't start the heparin. And so we held off on the heparin. And sure enough, we got a CAT scan, and she had a big, big head bleed. That was the first time I learned about this. So again, when you see these type of T-wave abnormalities with altered level of consciousness, none of these patients will be awake and alert. So they'll all be altered. Think about intracranial hemorrhage. Okay? Okay, last thing I'll leave you with. I started out this morning saying, if you forget everything we talk about today, please remember one thing. Actually, two things. The whole day can be summarized in 2 slides. All right? I didn't want to tell you that when we started because you'd leave. All right? So please remember, number one, you don't need to be a cardiologist to read EKGs. Okay? Anybody can read EKGs. It just takes practice. And secondly, one of my pet peeves is this concept that electrocardiography is a basic skill. And it's true, but that doesn't mean that we should relegate ourselves to having basic skills. All right? I hope during the course of today I've been able to show you that if you improve your EKG skills somewhat, you can make life-saving decisions and have that opportunity to save lives more often than you'd imagine. And you've got to be the expert in your hospital, not the cardiologists. They've got many other things to worry about. You're the one that gets EKGs. You're the one that has the chance to save a life when that patient is still in your midst. If you're going to wait till the cardiologist sees the EKG a couple of days later or after the weekend's over, it might be too late. But if you can make these diagnoses, you can save lives on a regular basis. And as we started out with this morning, that's why we all went into medicine. Right? So please, I implore you to improve your EKG skills. And if there's anything that I can do to help you, again, I love getting emails, EKGs. I've showed you a bunch of EKGs that people send me. If there's anything that I can do to help with that skill, please stay in touch and let me know. And I'll be happy to help in any way possible. And again, I want to thank you all very much for your hospitality, and enjoy the rest of the conference.